Welcome to this Step 3 review on chronic disease management, focusing on hyperlipidemia and coronary artery disease test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for cholesterol and heart disease, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the cardiology and pharmacology sections of your major review book and worked through plenty of practice questions before exam day. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for hyperlipidemia and coronary artery disease. Second, we will apply specific strategies for statin decisions, the risk calculator, stable angina, and care after a heart attack. And third, we will master the next best step question format for managing chronic cardiovascular disease. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach so you can move through these questions with confidence. Our first strategy is the primary versus secondary prevention split, and this single distinction unlocks a huge number of questions. The moment you read the stem, ask one thing: does this patient already have established cardiovascular disease? If they have had a heart attack, a stroke, stable or unstable angina, a stent, a bypass or peripheral artery disease, that is secondary prevention, and the answer is a high-intensity statin no matter what the cholesterol number is. Do not get distracted hunting for a lab value. If the patient has no known disease, you are in primary prevention, and now the numbers matter. Check the low-density lipoprotein, the diabetes status, the age, and the risk score. One shortcut to memorize: a low-density lipoprotein at or above 190 means a high-intensity statin all by itself, with no calculator needed. Strategy 2 is reading the risk calculator stem correctly, because the boards love to see whether you know when the score matters and when it does not. Here is the clean framework. If the patient is between 40 and 75 and has diabetes, start at least a moderate intensity statin. If they are in that same age range without diabetes, the 10-year atherosclerotic cardiovascular disease risk score is what sorts them, and a value at or above 7.5% favors a statin after a risk discussion. Now memorize the three groups where you skip the calculator entirely: known cardiovascular disease, a low-density lipoprotein at or above 190, and diabetes in the right age range. If you spot any of those, do not waste time on the score. Go straight to the statin answer. Now let us go through high-yield stem recognition so the patterns jump out at you. For stable angina, look for predictable chest pressure on exertion that resolves within minutes of rest or with nitroglycerin, usually with a normal resting electrocardiogram. The next step is typically a stress test, and the long-term medicines are a statin, aspirin, and a beta blocker. For the patient recovering from a recent heart attack, think of the 4 classes that improve survival. And remember the referral the stem will try to make you forget. And for statin intolerance, watch for muscle aches with a normal or only mildly raised creatine kinase. The trap is to abandon statins forever. The correct move is to pause and then re-challenge at a lower dose or switch agents. Let us work through our first practice question. A 55-year-old man with no history of cardiovascular disease has a low-density lipoprotein cholesterol of 165. He does not have diabetes. His calculated 10-year atherosclerotic cardiovascular disease risk is 12%. He has never taken a cholesterol medicine. What is the most appropriate next step in management? Look closely at the risk number, because that is the key the question is testing. Take a moment to decide on your answer before we walk through it on the next slide. Let us break this down step by step. Step 1. Spot the pattern. This patient has no known disease, a low-density lipoprotein under 190. And no diabetes, which sends us straight to the risk score. The reported risk of 12% is the number that matters. Step 2. Apply the rule. A 10-year risk at or above 7.5% favors starting a statin after a shared risk discussion, and 12% clears that line comfortably. Step 3. Eliminate the wrong answers. Reassurance and repeat lipids ignores an elevated risk. A fibrate is not first line for lowering risk in this setting. Coronary angiography is for symptoms or ischemia, not for screening a person with no symptoms. The answer is B. Begin a moderate to high-intensity statin after discussing risk. Here is our second practice question. A 62-year-old woman describes 6 weeks of chest pressure that appears when she climbs stairs and resolves after a few minutes of rest. Her resting electrocardiogram is normal and she is stable with no pain at the moment. She takes no cardiac medicines. What is the most appropriate next step in management? Notice the words predictable, exertional, and relieved by rest, and notice that she is stable right now. Take a moment to choose your answer before we work through it together. Let us work through this answer. First, read the question carefully. The pattern is classic stable angina, predictable pressure with exertion, relief within minutes of rest, a normal resting tracing, and a patient who is stable at this moment. Because this is not an acute event, the most aggressive choices are traps. Immediate angiography is reserved for higher risk or unstable presentations. Thrombolytics are for an acute heart attack, not stable symptoms, and giving them here could cause harm. Reassurance with no workup ignores real exertional chest pain. For stable, low to intermediate risk chest pain, the next step is a stress test to confirm ischemia before anything invasive. The answer is B, exercise stress testing. Let us review care after a heart attack for the boards because this comes up constantly. There are 4 classes of medicine that improve survival, and they are your high-yield answers: an antiplatelet such as aspirin, a high-intensity statin, a beta blocker, and an angiotensin-converting enzyme inhibitor. After a stent, expect dual antiplatelet therapy. When the pump function stays low, add a mineralocorticoid antagonist. Now here is the part students forget. Cardiac rehabilitation is a correct answer that gets overlooked again and again. It lowers death and rehospitalization and is recommended for nearly every patient after a heart attack. So when a STEM lists a patient already on all the right medicines and asks what else to add, supervised cardiac rehabilitation is very often the intended choice. Here is our third practice question. A 60-year-old man is seen 2 weeks after a heart attack that was treated with a stent. He feels well. He is already taking aspirin, a second antiplatelet agent, a high-intensity statin, a beta blocker, and an angiotensin-converting enzyme inhibitor, and his pump function is normal. What is the most appropriate next step to reduce future events? Notice that every survival medicine is already on board. Ask yourself what important step is still missing. Take a moment, then we will go through it. Let us break down this answer. The classic pattern here is a patient who is already on every survival medicine and feels well with normal pump function. When the STEM optimizes the medicines and still asks for one more step, it is steering you toward cardiac rehabilitation. Now eliminate the others. Adding a fibrate provides no survival benefit in this situation. Stopping the beta blocker removes one of the survival medicines, which is the opposite of what we want. Routine repeat angiography is not performed in a patient without symptoms. That leaves the answer. B. Refer to a supervised cardiac rehabilitation program. Here is a critical test-taking pearl about statin intensity and monitoring. High-intensity therapy is the answer for known cardiovascular disease, for a low-density lipoprotein at or above 190, and for higher-risk patients. Moderate intensity fits diabetes in the right age range or a borderline risk patient. Get a baseline lipid panel and recheck after about 2 months to confirm the response. Now the trap. When a patient reports mild muscle aches with a normal or only slightly raised creatine kinase, the wrong answer is to ban statins forever. The right approach is to pause and then re-challenge at a lower dose or switch to another agent. Also know that routine liver enzyme monitoring is no longer required. These distinctions show up often, so lock them in. That wraps up our review of chronic disease management for hyperlipidemia and coronary artery disease test-taking strategies for Step 3. Review the cardiology and pharmacology chapters in your major review book and your question bank, and focus on statin indications, the risk calculator, the stable angina workup, and care after a heart attack, including cardiac rehabilitation. If you found this helpful, please like and subscribe for more board review content. And for one-on-one help, visit www.roadmap2residency.com, where our expert tutors and residency advisors are ready to support you. Good luck on your exam.